Acute diarrhea. Scenario: a 22-year-old man who has just returned from a trip to Thailand is sent to the emergency department by ambulance after being seen by the out-of-hours GP service. He looks acutely unwell and is barely responsive to your questions, saying that he has had terrible diarrhea for several days. Introduction. This is an emergency. The patient seems to be suffering circulatory failure and neurological disturbance. In a recently returned traveler from abroad with severe diarrhea, the most likely diagnosis is an acute infection such as bacterial dysentery. Causes of severe diarrhea in the returning traveler: enteral infection, bacterial, Campylobacter, Salmonella, Shigella, Escherichia coli, Vibrio cholerae, if travel to an endemic area, Clostridium difficile, protozoal, amoebic dysentery, cryptosporidiosis, giardiasis, viral, rotavirus, Norwalk agent, CMV in the immunocompromised, systemic infection with diarrheal component, malaria, pneumonia, especially atypical, septicemia, meningitis, non-infectious, inflammatory bowel disease, drug side effects, especially antibiotics, laxative overuse. History of the presenting problem. The patient cannot give a detailed or reliable history, but from any source available, family, friends, GP letter, ambulance crew notes, try to ascertain the following. Travel: when did the patient return from abroad, how long was he there, and what precisely was he doing? Diarrhea: when did it start, how many times today and what is it like? Is the diarrhea watery, suggesting a non-invasive organism such as Giardia, Cryptosporidium, or cholera, or bloody, suggesting bacterial or amoebic dysentery or inflammatory bowel disease? Other symptoms: vomiting, fever. Have traveling companions been similarly affected? This would make an infective cause very likely. Medications: antidiarrheal agents may prevent the natural expulsion of stool and can worsen bacterial dysentery. Use of antibiotics may result in antibiotic-associated diarrhea and pseudomembranous colitis caused by C. difficile infection. Has the patient taken antimalarial prophylaxis, and if so, what? Other relevant history. Is there any possibility that the patient may have a non-infectious cause of diarrhea? Has he ever had any similar problems before, which would suggest that inflammatory bowel disease might be the diagnosis? Does he have any pre-existing medical condition such as diabetes, immunodeficiency, including HIV infection, or relevant family history of illness, e.g. of inflammatory bowel disease? Was the patient vaccinated against salmonella and cholera before traveling? NB. Just because a patient has been abroad, do not assume that it must be an infectious condition. Examination. General features. NB. Get help from the intensive care unit urgently if the patient looks very ill or nearly dead. Vital signs: look in particular for evidence of intravascular volume depletion, cool peripheries, tachycardia, hypotension or postural hypotension, low JVP, and dehydration, reduced skin turgor, dry mucosae. Check pulse oximetry. NB. If resuscitation is required, start immediately. Systemic signs of sepsis: skin rash, which may accompany typhoid fever and gram-negative sepsis from bacterial dysentery. Is the body temperature abnormally high or low, both of which can be signs of sepsis? Uveitis or arthritis can complicate dysentery. Glasgow Coma Scale, GSC, score, is the fact that the patient barely responds to questions the result of general debilitation, or does it indicate pathology such as cerebral malaria or meningitis? Abdomen. Is the abdomen tender or distended? This might indicate colonic dilatation, and possibly precede perforation. Are the liver and spleen enlarged or tender? Bacterial dysentery may result in splenomegaly, while amoebiases can be associated with liver abscess. Is the rectal examination normal, or is there a bloody or purulent discharge? This indicates probable dysentery or inflammatory bowel disease, and once the patient is stabilized, rigid sigmoidoscopy should be considered to obtain a tissue diagnosis. Investigation. NB. Always check thick films for malaria in a patient returning from the tropics with a febrile illness. Routine blood tests. FBC looking for anemia, leukocytosis, thrombocytopenia, a possible feature of sepsis, but also consider hemolytic uremic syndrome caused by E. coli 0157. Electrolytes, hypokaliemia, hypernatremia. Creatinine and urea, renal function, hydration status. Liver function tests. Inflammatory markers. Blood culture. Stool. Submit a stool sample for microbiological assessment, microscopy, culture, sensitivity, testing for ova, cysts, and parasites. C. difficile toxin. A freshly evacuated specimen needs to be examined if amoebiases is suspected. Imaging. Abdominal radiograph, looking in particular for colonic dilatation, toxic megacolon being defined as a diameter of the transverse colon greater than 6 cm, Fig. 12. Sigmoidoscopy. Rigid sigmoidoscopy with rectal biopsy should be performed if the patient has bloody diarrhea or is passing mucopus, suggesting dysentery or colitis, and particularly in an immunocompromised individual, where there may be viral colitis, e.g. caused by CMV, or cryptosporidial infection. This allows direct visualization of colonic mucosa and biopsy, see Fig. 4. Other investigations. The need for other investigations is determined by clinical progress and the results of routine testing, e.g. serological tests for amoebiases and ursinaiasis, also for celiac disease, may be appropriate. Management. NB. In a sick patient with an acute diarrheal and colitic illness, start treatment before the results of tests are available. Resuscitate. Ciprofloxacin, 500 mg IV BD, and metronidazole, 500 mg IV TDS to treat presumed bacterial or amoebic dysentery. Hydrocortisone, 200 mg IV QDS to cover the possibility of inflammatory bowel disease. Surgical review, in case there is actual or impending colonic perforation. NB. Obtain a surgical opinion, preferably from an experienced gastroenterological surgeon, immediately if there is peritonism or the abdominal radiograph shows toxic megacolon or free air, or if patient does not improve rapidly with rehydration and the treatment listed above. Emergency colectomy may be required. Further comments. Is there a public health issue? Are others affected? And was the airline's caterer rather than the roadside food vendor in Bangkok to blame? NB. Public health issues. Food poisoning and dysentery cases should be notified to the Public Health Laboratory Service, which will consider instigating case finding and source tracing of any outbreak. The attending doctor could reasonably offer testing and treatment to known contacts of the index case. NB. If dealing with acute gastroenteritis in the field, Remember the World Health Organization and UNICEF oral rehydration fluid, 1 L water, 10 grams, 2 teaspoons, sugar, 2.5 grams, 1/2 teaspoon, salt, 2.5 grams, 1/2 teaspoon, baking soda, sodium bicarbonate.